We're joined on the line by Dr. Scott Atlas. He's a senior fellow at Stanford University's Hoover Institution, a member of the institution's working group on healthcare policy, previous chief of neuroradiology at Stanford Medical Center. Dr. Atlas, thanks so much for joining the show again.
Sure. Thanks for having me.
So as we look at these increased modeled numbers, suggesting anywhere from 134,000 deaths to 200,000 deaths by the end of August, yeah, I'm frankly a little bit surprised at the amount of press this is getting, given the fact that eventually these lockdowns were going to end. Everybody understands that as the lockdowns end, more people will go out, and that the risks from COVID-19 have not been mitigated. I'm wondering exactly which factors do you think are lacking when it comes to releasing people from lockdown in gradual fashion?
Yeah, if I can clarify something about the models first, those figures that were just received from the IHME model have nothing to do with lockdown being released. Those figures are just simply updates based upon data coming in that we are already seeing. So the fact here is that these hypothetical projections shouldn't be obsessed over. All they do when they change every 3 to 4 days is point out the inaccuracy of their own projection. This is not based on changing policy. That's point number one. Now, your question was what should be done on reentry? Is that what your question is?
Yes.
Sorry about that. So, I mean, the basic points here are using what we know, which is the realistic approximation of fatality rate and who's vulnerable. We need to focus, point number one, very stringent access to the most vulnerable people, the tinderbox of people that are living in nursing homes and senior care centers. And what I mean by stringent requirements in an already regulated environment, because you can't just walk into a nursing home anyway, should be done things like actually requiring testing. Okay, you can't have somebody who's coming in there and cleaning the floors who might be infected, or who's touching these patients or working with them. This is sort of obvious point number one, targeted, strict control. Point number two is people who have mild disease, who are sick and have some kind of fluish symptoms, respiratory symptoms, they have to assume they have the disease and self-isolate. You don't need a test for them. What you urgently need is to protect the vulnerable. And the way you do that is to let people know that if they're sick, they have to self-isolate, assume they have the disease. The other things to be done really are to make sure that you have not incited fear in the public and instill rational trust and in their experience in self-isolating. And what I mean by that is they know who's vulnerable. They know their elderly family members, for instance, people with underlying conditions, particularly diabetes and obesity, are vulnerable. Use the standards of hygiene that we now know. No one knew about social isolation before. We know what social distancing is, but that doesn't mean confining people into their homes. It makes no sense. There's no real evidence that it's better to be strictly confined inside your home, or that we should keep K through 12 schools open. And I can talk about that in detail, but young children, people in the K through 12 age group, we know overwhelming amount of evidence that these people have very little, if any, risk of serious illness from this virus and essentially zero risk of dying. You don't have to keep them confined in their homes or even have 6-foot spacing between them. If you keep them confined in their homes, not only are you missing education, but you're locking up the ability of their parents to go to work. There's a massive, really harmful nature to some of these restrictive policies. Similarly, there's no evidence to keep people inside and lock down parks and beaches and outdoor facilities. That was done to prevent this kind of very close proximity mingling. But even when we know, even if you wanted to have that, there's no reason to close a park. I mean, that's just really, there's no evidence for that. And what these policies have done, Ben, is they have done something very harmful, not just locking down medical care and people are dying because of that, and the massive harm from the economic isolation, but they have instilled fear and panic in people. And you're seeing probably where you live, certainly where I live in California, I see people who are driving around inside their own cars with no one else in them wearing masks. And believe me, I'm not implying something wrong with these people or are underestimating their fear. I'm saying it is an indication of the fear from very poor leadership and very really lack of consideration of science and using logic to use appropriate policy.
So, Dr. Atlas, I've been in the last couple of days considering a question, and it was actually raised by a column that you wrote for The Hill in sort of contradiction to an article that was written by a guy named Harris over at the New York Times. And this was with regard to social distancing itself. What are the goals that we are attempting to achieve here? The reason that I'm asking this question is because it seems like basically we are now trying to figure out what to do based on future projections. On the one hand, you have folks who say, okay, well, a vaccine will come, it will be imminent, it will happen quickly, or there will be a therapeutic that will happen quickly, which would suggest you lengthen the lockdowns, you create lots of social distancing so as to flatten the curve until we get to some sort of deus ex machina that radically changes the math. On the other hand, there's the possibility that nothing changes, that we're 2 years out. We still don't have a vaccine. There's been no serious therapeutic that's been developed that radically lowers the death rate. And then the question is, why wouldn't we have preserved herd immunity among the non-vulnerable populations? In other words, you make sure that the people who are most vulnerable are protected. You make sure that the nursing homes are really well protected. You make sure that people who are obese or who have prediabetes are staying home as much as possible and are isolated from other people. And then you actually encourage the 60 to 70% of the population that does not have any of these conditions to go out, and you actually want the COVID to move through the population and create herd immunity. That's sort of the Swedish strategy. It seems like we've sort of split the baby here, where we are on the one hand suggesting that we are not pursuing herd immunity, and on the other, and that there will be some radical change that will happen in the very near future. And at the same time, we want people to sort of go back to work and sort of isolate and sort of not isolate. What is our goal here? Should our goal here to be assuming that there's some sort of radical change to the system in the form of therapeutic or vaccine, and thus we should really mitigate the amount of social contact we have with one another? Or should we be assuming that none of that may be forthcoming, and so we should actually pursue herd immunity, because every month we don't pursue herd immunity is another month of lengthened time where the economy is dead and where huge percentages of the population have to stay home?
Okay, so you're pointing out really one of the major flaws of logic and common sense, honestly, that's being used by people, including very smart people. The point here is that there is no reason to do some of these sort of illogical isolation policies, regardless of if there is a vaccine or not. I want to come back to the vaccine point. But the goal of the policy, this is your first question. The goal of the policy was stated, and it has been twofold. Stop the people from dying who are the most vulnerable, which that goal, honestly, there's a problem with how that was sort of ignored in a sense, but to flatten the curve. What does that mean? Curve has nothing to do with number of cases. The curves to be flattened that have been flattened are curves on hospitalizations per day and deaths per day, to prevent overwhelming of the hospitals and to understand that you sort of have controlled the progress of death. There's a nuance to this that's sort of going to bore your audience, but the reality is flattening the curve has nothing to do with changing the area under the curve. Correct. If you listen very early on, the point was to prolong and slow down and somehow reduce the overwhelming of the medical system in sort of in an out of control way, so that we could administer care and control the kind of out of control sort of overwhelming issues. But it was not really, honestly, to reduce the deaths. The reduction of deaths should be this targeted policy of protecting the vulnerable. We know who they are. Now, the idea, I want to mention something about the idea of vaccines. There's this sort of naive interpretation of what a vaccine does and when it will come out. Okay, and this is not really, I'm not trying to criticize people, but the general public and even people in this debate have been very naive about this. Vaccines are not magic wands. Typically speaking, it's very common that a vaccine, particularly for a respiratory virus that has some evolution and changing that occurs, like let's talk about influenza, 40 to 60% effective. And we've been working on vaccines for influenza for many, many years and have a lot of experience. That's point number one. There's no magic wand here that all of a sudden it's 100% effective. We don't know. We have no idea about that. But we know from other infections that it may not be. The second point is that despite the vaccines, in influenza, 400,000 to 650,000 people die in the world every year from seasonal flu with the vaccine. Okay, so, the vaccine is not a magic wand. point B about the vaccine is that vaccines are not ready tomorrow. Vaccines are not going to be ready in a month. The vaccine technology has dramatically improved, and things are done with a massive amount of intention and rapidity and an incredible effort by the private sector in the US and the academic sector, as well as in the UK and elsewhere. Lots of vaccines are being looked at, probably 100 roughly. And a couple of them have a significant amount of promise. When will they be ready? When will they be ready for production? When will they be ready for implementation? We're talking many, many months. So we don't know exactly when. It's highly unlikely in my view, and it's impossible to predict because I'll predict and I'll be way off, but not going to be happening before 2021. I mean, almost certainly. And, even with the best case scenarios, we have to realize vaccines are not magic wands. Meantime, we can't ignore this. Massive harms from the current policy. Extending total isolation is killing people on the basis of the medical care and a catastrophic economic problem, which converts into healthcare and poverty and death all over the world, to the likes of which really people have not really calculated.
So final quick question for you, Dr. Atlas. So there's been people who've been pushing, some Israeli scientists, something called controlled avalanche, which is basically make sure that everybody who is vulnerable is protected, and then actually encourage people who are younger to not social distance. And you sort of mentioned something like this in your article for The Hill. So is that something that we should be seriously considering? Just saying, if you're under the age of 40 and you're healthy, you should go out, you should go to ball games. And if you get coronavirus and then you get over it, then you've actually added to the health of the country.
Ben, this is really hitting the nail on the head, sort of, with the basic premise of immunology and decades of knowledge about viruses. It's actually a negative to interfere by total isolation with herd immunity. Herd immunity is necessary, and it is the most immediately available way to break the connections toward the vulnerable in this contagious sort of disease. So it's actually detrimental to lock everybody up and prevent the low-risk groups, like you're saying, to get the disease. 50% of people are zero symptoms. Over 95% of people, probably 99% of people, have very mild disease. There's nothing wrong with that in the low-risk groups. The focus should be preventing the people who are the vulnerable. We know who they are. It's harmful to prevent mingling by other people.
Well, Dr. Scott Atlas, Hoover Institution, really appreciate your time, sir, and look forward to speaking with you again soon.
Okay, thanks very much for having me.
I hope you enjoyed that clip from The Ben Shapiro Show. If you did, go ahead and hit the subscribe button so you stay up to date on all of our future content.